So it could help you predict, hey, you're in a high-risk group. You should definitely get chemotherapy versus a low-risk group.
Okay. This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guests are Eric Miller and Vidya Arole. Eric is an MD and PhD and a radiation oncologist who specializes in treating patients with gastrointestinal cancer, such as colon cancer. Vidya is an assistant professor in the Department of Pathology and an expert in the pathology of gastrointestinal cancers, including colon cancer. Together, they will fill us in on how pathologists have traditionally reviewed tissue specimens and how digital pathology and AI, artificial intelligence, is helping them better understand this process and how this impacts and can help guide treatment and lead to better outcomes for patients. Welcome, both of you, to the podcast.
Hello, thank you so much for having me here. I am excited to talk to you.
I'm excited to have you here and learn all about this because this is very interesting because you each do something different, but as we'll get to eventually, you've come together for this artificial intelligence treatment. So I thought it would be a good way to start if you both give us a little overview of what you do on your main jobs. And Vidya, why don't you start?
Okay, so I am a pathologist, as you mentioned, specialized in gastrointestinal pathology. So in simple words, we are the doctors who give diagnosis by looking into the tissues and cells under the microscope traditionally. And we play a vital role in identifying underlying etiologies like cancer, infections, or inflammatory processes, and help other doctors like Dr. Miller here to aid in appropriate treatment for the patients. So I like to consider myself as doctor's doctor.
A doctor's doctor. I like that. And you mentioned it's not just cancer. There's all sorts of things you see. We sort of focus in on cancer, but there are many different problems you can see in these pathology reports and biopsies. Okay.
And sometimes they're surprising. Sometimes it's clinically cancer, but it turns out to be just infectious process. So it's very rewarding to see how we contribute and solve the puzzles.
Okay, and Eric, after you've gotten this report, what happens next?
Yes, I'm a radiation oncologist here at the James. I specialize in GI cancers, and essentially what radiation oncology is, most people think that we sit in dark rooms and look at images. We do that to some degree, but we're not interpreting the images. We're taking the clinical information, we're evaluating the patient, doing history and physical exams on the patient, looking at the clinical information and the pathologic information that Dr. Arole provides. And we take that information, we talk to the patient about their treatment options, and we consider if radiation as a treatment makes sense. And so that's really our job is the radiation part of their oncology treatment. And so whenever a patient comes to see us, we look at the overall picture, we look at imaging, we look at the pathology report, which essentially provides information about the tumor, potential risk factors that the tumor has for potential spread, and we take all that information into account whenever we decide if a course of radiation therapy makes sense for the patient. And so we work in concert with pathologists and surgeons and medical oncologists as well.
So it sounds like for both of you, it's a little bit of an art form and a craft to come up with your pathology report, and then Eric, for you to how you utilize this in radiation. It's not always cut and dry. It's not A, B, C, D. There's all kinds of steps and interpretations, it sounds like.
Yeah, there's certainly pathways that we follow and guidelines that we follow, but that's why we call it the practice of medicine, because I think patients are sometimes surprised that there isn't always a cut and dried answer. It's all about it's clinical experience. It's taking into account the literature that's available, and that's how we kind of make treatment decisions. And the decisions aren't always perfect. In reality, and that was one of the impetuses for this project, is that we do things where the benefit for the patient might be fairly small. And so more information about risk factors and where a patient may benefit from a certain treatment is certainly warranted in oncology treatment nowadays.
And I also know from previous podcasts and talking to other people that in each of your fields, technology and new innovations are really changing how much you can do, and you can help patients even more. I know from pathology that the James is a leader in digital pathology. So kind of give us a sense of what that is and how that's helped you do your job even better.
So traditionally, I would say we are trained to look into the microscope to give the diagnosis. But here at Ohio State University and James, we have fully integrated digital pathology workflow where when the tissue samples come from the patients, they are made into glass slides, and these glass slides are converted into whole glass slide images.
Glass light images.
Yeah, or you can say whole slide images, WSIs.
What do they actually look like on your computer screen? Is it like, I'm thinking when you see on TV, it's like dark and light shadows. Is that sort of what it looks like?
So it exactly looks like how it would look under the microscope. It appears on the screen. So we use different staining techniques, which gives pink and blue colors to different parts in the tissues. And it just doing the same thing without looking into the microscope. So they appear on the screen with the similar features, I would say. Do
different colors mean different things?
Yes, for sure. Most of the time, the standard practice is to use something called as hematoxylin and eosin, which gives blue and pink color. So most of the pathology slides are pink and blue. So we call our world pink and blue.
Pink.
But sometimes we do additional testing, which is called as immunohistochemistry, and we can use, or sometimes even special stains, which can give different colors to different tissue, and it can have a beautiful appearance. So it's pretty, for sure, with different colors. Sometimes brown, sometimes magenta, and yellow. So wow. It's not black and white like radiologist, I would say.
And what do cancer cells or a cancer tumor look like when you're looking at them?
So when compared to the normal, they are larger. They have disorganized pattern. They are proliferating at higher rate. So we see extremely rapidly dividing cells, which will have some features within their nuclei, such as mitosis. Or sometimes we see tumor is going into blood vessels, which is a sign that it is definitely a cancer. So these soft features help us to come up with a diagnosis.
So Eric, I know advances in radiation, which is still one of the main treatment forms for cancer. There's been a lot of advances, including the James is one of the few places with proton radiation. So what technological advances have helped you in the past decade or so?
Yeah, so a couple big things. One is the ability to deliver really high doses of radiation to tumors. And so we're able to treat metastases like we never have before. So for colorectal cancer, for example, a lot of the metastases are in the liver and in the lungs, and also lymph nodes. And so with techniques like stereotactic body radiation therapy, we're able to deliver ablative, very high radiation doses to these tumors and kill them. And with imaging the way that it is now, we can detect more of these tumors than ever before. So we're able to target them better. And so that's really one of the advances that we've really developed over the last decade or two. And we're kind of getting a better idea of how to use it and when to use it. And we have some ongoing clinical trials, including some here at the James, and one that I lead nationally, that's really trying to answer this question of when to use this type of therapy and what patient scenario. Protons is another really big advancement over the last several decades as well, and we're excited to have it here at Ohio State. And the big key with protons is that it's a large dosimetric advantage compared to regular types of radiation treatment. And what that means, in kind of plain words, is that if we're treating a liver tumor, we're able to spare more of the liver with protons than we can with photons. And so the reason why that's important is that a lot of these patients are living much longer than they ever did before. We have better lines of systemic therapy. And so if you're able to spare as much normal liver as you can and other organs, potentially you can prevent that organ from having dysfunction later on in life, and you can potentially deliver more treatments. So that's one of the big developments here at OSU, and really excited to have the technology here.
Another thing I've learned a little bit about is that radiation in combination with chemotherapy, and now even more so with immunotherapy, that multi-approach treatment seems to work even better, and that even as immunotherapy grows and is being used more, the radiation will still be part of treatments?
You're exactly right. So there is some evidence out there that combination radiation with immunotherapy may sensitize tumors that aren't being radiated to treatment as well. And not just immunotherapy, we have other targeted therapies that we're exploring as well that help the radiation work better also, and potentially can increase response rates and potentially result in better clinical outcomes.
Okay, so that was a great overview of what each of you do, and we're going to take a quick break, and when we come back, we're going to see how your two fields came together to create something new.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Eric and Vidya, and I'm very curious how you two, I guess, met and came together on this new research study to use AI in each of your work.
So I met with this group of research scientists from Norway in one of the pathology conference, and they had a tool for stage 2 and stage 3 colon cancer patients, which they have already, they said, which is validated on patients in European cohort, and they wanted to do something similar in patients in United States. And we decided to collaborate with them, and one of the pathologists introduced me with Dr. Miller to sort of...
One of the pathologists from Norway?
No, from
here?
Ohio State
Okay.
University. He's also a digital pathologist.
Okay.
So,
so when you went back with your colleagues in digital pathology, he said, Eric is the person you should team up with. Let me introduce you. Okay.
Yes.
Yeah, so I this was my first kind of experience with the pathologist in a research setting. I will say, like, we do meet every single week at a multidisciplinary colorectal tumor board where we discuss patients and pathology and surgeons, including Dr. Arole. I think you were at that conference weekly for the last, 2 years?
Yeah, one year.
Pretty much never missed the meeting. So we work together to talk about how to manage situations and how to manage.
You already knew each other.
Yeah, we knew each other kind of from that meeting.
Yeah, okay.
But Dr. Lujan and Dr. Arole kind of approached about, hey, like, we have this tool, where do you think we can use it? And at the same time, by the way, we also have like one of the largest digital pathology repositories
in the world.
In the world, which I didn't even really know that. So that was really amazing to hear as well. And so we kind of grouped together and met with the group from Norway and saw where we could potentially collaborate. And we treat a lot of patients here at the James. We have a lot of patients that have been treated over the last couple of decades. And so we kind of formulated a plan to also validate their tool here in the United States using the patients that have been treated at the James.
So explain this tool and I guess what the name of it is and what it does.
Yeah, good.
Okay. So it's called Histotype PX.
Wait, say that again.
It is Histotype PX.
Okay.
It's similar to what, if you've heard before, Oncotype DX, which is like artificial intelligence-based biomarker, and maybe Dr. Miller can talk more about it.
Yeah, and so it's, like all things in AI, it's a bit of a black box, but what the Norway team had done is they had trained this algorithm on patients, and they knew the outcome. So they had the algorithm look at the slides, look at the whole slide images that Dr. Arole mentioned, and they knew the outcomes. And so they basically trained the algorithm on thousands of patients that were treated in Europe. And so it had an idea that, okay, if you see this feature, this is the outcome. And so that's how the algorithm was trained. And then the next step that we were doing here at OSU was to then basically run the algorithm again on patients that were treated here where we knew the outcome, but the machine did not, to see if it could accurately predict outcomes in patients that were treated outside of their European group of patients.
And did it accurately predict?
It did a pretty good job. So we started with a limited number of patients here, 159 patients in our initial study. And it really, the results, while it's a smaller patient number, were really promising and really encouraging, which has kind of led us to do a larger study here.
So when you say it would predict, what would it predict exactly?
So it really was able to predict patient outcomes. And so it did a couple things. So one of the things that it looked at was, in the patients that we had treated here, was whenever you're considering adjuvant therapy or additional treatment after surgery. So these are patients who had colon cancer, had surgery, and then sometimes patients get adjuvant chemotherapy or additional chemotherapy afterwards, and sometimes they don't. And it really depends on a lot of features that really Dr. Arole helps us decide on. So she looks at the slide. She says, oh, yes, it has this risk feature, it has this risk feature, it doesn't have this risk feature. And then, medical oncologists, not really radiation oncologists, but medical oncologists look at the pathology report, and then they decide, okay, well, I think this patient has enough risk factors that they should get additional chemotherapy. And so what the algorithm was able to do was, independent of those risk factors, be able to say, okay, just looking at the slide and adding in a little bit of clinical information, you are in this risk category. It gives you a high, an intermediate, and a risk or a low risk category, and it tells you, hey, you're in this risk category. And what you do with that information is kind of, these are our patients who are already treated, so we kind of knew the answer, but that could be like a future kind of way to use the algorithm. So it could help you predict, hey, you're in a high-risk group, you should definitely get chemotherapy versus a low-risk group.
Okay, that's the key. Is if you're in the high or even medium to high, you're going to probably need chemo after surgery because there's a chance that you didn't get every cancer cell.
Correct. Yeah. The way we do it now is, again, it's pulling the information from what Dr. Arole sees and from the pathology report, but in reality, we overtreat a lot of patients. So up to maybe even 80% or higher percentage of patients get chemotherapy and probably don't necessarily derive a benefit. And at the same time, there are some patients that we look at the pathology report and we're like, oh, I think they don't really have a lot of risk features, so they really don't need additional treatment. And in reality, they do, based on what the algorithm is seeing, which is a little unsettling, but we clearly don't know everything that the algorithm is seeing whenever it's looking at the slide compared to a human looking at the slide.
Well, that's a great point. And as a human looking at the slides, kind of explain how the AI helps you determining who's going to be high risk. What is it picking up that a pathologist either couldn't see or might not see?
That's a very good question. So nobody knows the answer. So it picks up the features which are beyond our neural networks. Like we are trained. We are trained to see certain things. And we just base our pathology findings on that. And sometimes there are subtle features which can be picked up by these artificial intelligence-based algorithms. So I think it's picking up something which is beyond that visible to the pathologist, basically.
Now, I'm not sure if you're going to be able to answer this, but is the limitations of human eyesight something that AI can overcome, that they actually see better than the human eyes?
I would not say they see better. It's like having a second pair of eyes for a pathologist.
Now, will the AI help train you to better pick up these features that you previously haven't seen?
That's the future, I think. And that's how I feel is it's an aid, but it cannot do the whole job of the pathologist. It will pick up certain things, but it cannot replace the pathologist because it's not 100%.
So it started in Norway, it came here to the United States and the James and the two of you. So where are you in terms of patients, in terms of utilizing this You said you've already used it on patients who have previously been diagnosed and been through surgery, but how soon will it be part of the standard of care? Or
yeah, it still has a way to go here. I know that's really one of the goals of the company that we're collaborating with, Do More Diagnostics in Norway, is one of their goals is to validate it in the U.S. Data set to make sure that it performs equally well in European and U.S. patients. And so the next goal that we're currently working on right now, and Vidya has an upcoming presentation in Florida in the fall. So we're looking at increasing the patient numbers, so looking at a larger group of patients to make sure that the results that we saw initially with a smaller group of patients still stands. And then really after that, it'll be working on implementing it in a clinical trial, so trying to work on incorporating this biomarker, like the other biomarkers that we typically use in clinic, like so actually using it for patients that we're seeing in clinic.
So when it comes to a clinical trial, you will use AI in your pathology report that you will give to doctors, and that will, I'm guessing, impact how the patient is treated?
Mm-hmm.
Yeah, that would be the idea. It could be provide additional information that the oncologist could then use to decide on the next, the treatment course,
and lead to more precise, personalized treatment for that particular patient.
That's what we hope. That's what we think the outcome will be, and that's the goal. I think the other important thing is that I think Dr. Arole mentioned it earlier. So they do additional slides I'm a non-pathologist, so this is my rudimentary understanding, but they do a lot of other slides or additional stains on these patient slides that they're getting, and that can take time. It can be more expense. The H&E slide that they're getting, or H&E staining that they're doing, is like the standard.
What, H&E?
Yeah, the hematoxylin and eosin, was it blue and pink that you had said?
Oh, okay.
It's the standard slide. It's the thing that they always get. And one of our thoughts is that this is a biomarker that's fairly quick. The algorithm can process the slides very quickly and pull out the information. So you don't necessarily have to do additional stains or get additional slides, and could also provide additional clinical information that you couldn't get even with the additional stains and slides. So it could be a faster way of coming to some of the conclusions that take a little bit longer and are more expensive right now.
Oh, okay, that makes sense. And one of the things I find fascinating about this is that you're collaborating with scientists and physicians in Norway. And collaboration is all over the world is what moves cancer treatment forward. And that's just fascinating to me, that the whole idea of collaboration, that all the world's leading comprehensive cancer centers work together like this. And just give me a sense of that, what it's like that you have colleagues all over the world that you can get involved in this.
The group of people from Norway are basically computer scientists and some physicians who have knowledge about colon cancer. So it's integrated approach. They have done the similar thing, looking at the tissue specimens from colon cancer patients back there in Europe. So they have some knowledge about how to implement this here. So it's great to have a team who has done this in the past. So it aids the process, like sharing the images across the globe, because that's the most challenging part, I feel, currently, is to share the data with different researchers in different parts of the world.
Well, that's a great point of sharing the data, because I'm guessing that when you go to this conference in Florida in the fall, you'll be sharing what you've learned so far with pathologists from all over the country and beyond who may be interested in getting involved in this?
Yeah, I would say so, because there are pathologists who specialize or practice digital pathology, and they're always interested in looking into the tools that are actually clinically relevant, meaning that they will eventually help patients in getting better care. So this is one of that, and it would bring a lot of interest in different pathologists, as well as I think there are not just the pathologists in those conferences, but the computer scientists who wants to learn what's happening and how it's been implemented, or what's the what's the outcome going to be for, like, what's the clinical outcome is going to be? Like, is it possible to utilize it in real world to treat the patients?
So I'm guessing that over the next few years or even decade, you two will be getting a lot of calls and asked to speak at a lot of conferences from people who want to do this.
Yeah, we hope so. That's the goal. I mean, it's exciting to be on this side to help patients and other clinicians to give better patient care, basically.
Yeah, for me, I always say I kind of entered medical school a little bit later in my life. I kind of did graduate school first and then went into medical school. And cancer really wasn't on my radar at all in terms of things I was thinking about doing. But I think when I got into my clinical rotations, I was just really struck by the oncology patients and just what they were going through and just the complexity and just a lot of them just being thrown into the medical system really quickly and having to process everything. And I couldn't see myself doing anything else. And so for me, it's really just helping decrease the burden of cancer for our patients and radiation oncology specifically, just because we do a lot of palliative treatments, we do a lot of curative treatments, and for me, the research research opportunities were just amazing, and my research goals are really trying to come up with better therapies to treat patients and to help with side effects of treatment and really to help patients just have this be a part of their life that they move on from and go on with the rest of their life and their families and live a full and fulfilling life.
Congratulations and good luck on your collaboration with using AI for digital pathology for colon cancer, and hopefully down the road you'll be world leaders and this will help a lot of people.
Yep. Thank you so much.
Thank you for having us.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.